Welcome to our case study of Harumi, who has hypothyroidism as a complication of Hashimoto's disease. We'll be looking at the pathophysiology, pharmacological interventions for, and nursing interventions in an acute setting for Hashimoto's disease. Presented by Steph, Amy, and Ricky. Harumi is presenting to the emergency department with severe constipation and dehydration as a result of an underactive thyroid. She is a 62-year-old female of Asian ethnicity, all of which are risk factors for Hashimoto's disease. Upon further investigation, she states she retired 2 years ago from a secretarial position. She is recently widowed and has a 28-year-old daughter currently living out of state. She has a history of rheumatoid arthritis, currently controlled with immunosuppressants. She had a cesarean section birth in 1989, and she has no history of tobacco use or smoking. Harumi reports that for the past few months she has felt tired and fatigued for no apparent reason, has been gaining excessive weight, and has difficulty moving her bowels. She also reports feeling increased sensitivity to the cold. On assessment of her vital signs, the nurse finds her blood pressure is 90/60, her heart rate is 65 beats per minute, her oxygen saturation is 98%, and her respiratory rate is 13 respirations per minute. Her current temperature is 36 degrees. Further assessment shows she has cold, dry skin, edema in the face and extremities, and muscle weakness, all of which are consistent with hypothyroidism as a result of Hashimoto's disease. She has a high BMI of 32, which places Harumi at a higher risk for Hashimoto's disease. She has also been experiencing difficulty in staying awake and reports she has been sleeping excessively. She is currently having difficulty in completing her ADLs. The subsequent lab results show she has the presence of thyroglobulin antibody, thyroid peroxidase antibody, and thyroid stimulating hormone stimulation blocking antibody. The lab results also show she has increased serum levels of thyroid stimulating hormone, and all of this information leads us to a diagnosis of Hashimoto's disease.
And is the largest pure endocrine gland in the human body, located at the front of the trachea just below the larynx. It is comprised of many hollow, spherical follicles lined by epithelial cells. These epithelial cells produce thyroglobulin, which is expelled into the colloid of the lumen, where it will be iodinated. These cells will be the target of the autoimmune attack discussed later. This brings us to the primary function of the thyroid gland, to produce thyroid hormone. This actually includes two hormones, thyroxine, or T4, and triiodothyronine, or T3. These hormones increase the metabolic rate of cells and the body's heat production. They regulate tissue growth and development and maintain blood pressure. It is important to note that levels of thyroid hormone are regulated by negative feedback. When serum levels are low, the hypothalamus secretes thyrotropin-releasing hormone, which stimulates the anterior pituitary to secrete thyroid-stimulating hormone, thus stimulating the thyroid gland. Hashimoto's thyroiditis is an autoimmune disease, which means that the body has misidentified its own cells as foreign and begun attacking them. The key processes include lymphocytic infiltration, fibrosis, and epithelial cell death. Let's begin with lymphocytic infiltration. This describes white blood cells entering the thyroid gland abnormally. Cytotoxic T cells are the primary players, destroying the thyroid epithelial cells via necrosis and apoptosis. Local T cells produce cytokines that impair thyroid function and induce the expression of pro-inflammatory molecules. The B cells involved in this response become memory cells and plasma cells, the latter of which produces antibodies that attack the thyroid cells. The antibodies active in this disease are thyroid-stimulating hormone stimulation blocking antibody, or TSH stimulation blocking antibody, which prevents thyroid-stimulating hormone from binding to receptors on the thyroid, and thyroglobulin antibody, which binds thyroglobulin, preventing the synthesis and release of thyroid hormone. Whilst initial damage to thyroid cells may cause them to leak excess thyroid hormone, leading to temporary hyperthyroidism, these processes lead to reduced thyroid function and hypothyroidism. Risk factors for Hashimoto's include being a woman, increased age, Asian ethnicity, a high iodine or low iodine diet, certain viral infections, such as congenital rubella syndrome, genetic predisposition due to polymorphisms of the HLA-DR gene, smoking, and an increased BMI, many of which are shared by Harumi, our case study. We chose to give Harumi signs of hypothyroidism, which is actually a complication of Hashimoto's thyroiditis. Hashimoto's itself is a subclinical disease, meaning it is generally not severe enough to present definite or readily observable symptoms until such complications arise. Hashimoto's manifests in two forms: goitrous, where there is an enlargement of the thyroid gland, known as goiter, and atropic, where there is comparatively more fibrosis and the thyroid gland shrinks. However, it is not known whether autoimmune atrophic thyroiditis is a distinct disorder or is a stage of goitrous thyroiditis. Note that goiter may develop as a result of an iodine-deficient diet, which prevents the synthesis of thyroid hormone and causes hypothyroidism. This, however, is not the same as Hashimoto's thyroiditis. Complications of this disease are vast. If a woman is iodine deficient during her pregnancy, or there is a congenital defect in thyroid hormone synthesis, the fetus may develop cretinism. This results in dwarfism, coarse skin and facial features, severe brain damage, and neurological conditions. The second and most common complication in adults is hypothyroidism, due to a decrease in thyroid hormone production. This can result in somnolence, slow mentation, dryness and loss of hair, lower body temperature, muscle weakness, hoarseness, and delayed relaxation of tendon reflexes. This may progress to myxedema, which incorporates all of these symptoms, especially a firm, waxy swelling of the skin and subcutaneous tissue, weight gain, and mental dullness.
Thyroxine sodium is indicated in the use of thyroid hormone deficiencies and management of thyroiditis, example Hashimoto's disease, and TSH responsive thyroid tremors. It comes in tablets of 20, 75, 100 or 200 micrograms, and it is converted to the more active T3 form in the body. Slow onset of action 3 to 4 weeks and a long duration of 7 to 21 days, even when thyroxine therapy is stopped. Its half-life for hypothyroidism is 9 to 10 days. It starts with an initial dose of 25 to 50 micrograms orally daily before food on an empty stomach, increasing at 3 to 4 weekly intervals to 100 or 150 microgram daily as maintenance. Or, in the elderly, it is 75 to 125 micrograms orally daily before food. Adverse effects they're usually associated with overdose and can consist of the following: nervousness, restlessness, anxiety, sweating, flushing, headache, insomnia, sleep disturbance, poor concentration, mania, seizures, tachypnea, shortness of breath, tachycardia, palpitations, cardiac arrhythmias, myopathy, muscle cramps and weakness, diarrhea, vomiting, weight loss, alopecia, hyperpigmentation, decreased libido, menstrual irregularities, and decreased glucose tolerance. Now, the drug interactions. Thyroxine sodium interacts with many common medications. It may enhance the effects of warfarin, requiring close monitoring of prothrombin times. It may reduce the effects of digoxin. Use with ketamine may result in marked hypertension and tachycardia. Increase in therapeutic and toxic effects of thioronine and tricyclic antidepressants if given together. Coronary insufficiency may occur if given with sympathomimetic agents such as adrenaline or dopamine. Higher doses of insulin and oral hypoglycemics may be needed, and careful blood glucose monitoring required. Lithium may result in inhibition of thyroid hormones, leading to clinical hypothyroidism. Effects may be reduced if given with sertraline or other SSRIs. Therapeutic effects of beta adrenoreceptor blocking agents and amiodarine may be reduced due to decreased peripheral conversion of thyroxine. Ciprofloxacin, which is an antibacterial, may decrease absorption of thyroxine if given together. An increase in dose of thioronine may be needed if given with estrogen in patients with a non-functioning thyroid gland. The clearance of corticosteroids may be decreased in hyperthyroid patients, and therefore corticosteroid dose may need adjusting. Decreased dose may be needed if given with androgens, and the use of anti-epileptic agents such as carbamazepine and barbiturates, rifampicin or ritonavir with thyroxine may result in decreased plasma levels. The effects may be reduced by cholestyramine, cholesterol, soya flour, or antacids including aluminium hydroxide, calcium carbonate, magnesium hydroxide, and also ferrous sulfate. Thyroid function tests can be modified without changes in clinical effect of thyroxine by some NSAIDs, salicylates, diazepam, heparin, and phenylphenate. Liothyronine sodium comes in 20 microgram tablets. It's also called L-triodithyronine. It is similar to thyroxine sodium but much more potent. It is rapid in onset, generally a few hours after administration, has a briefer duration of action and disappears within 24 to 48 hours of stopping therapy. It has a prolonged half-life in hypothyroidism. It is used for severe and acute hypothyroid states, myxedema coma, and the dose for myxedema is 10 to 20 microgram orally, 8 hourly, increasing gradually to a total of 60 microgram daily in divided doses, or for a myxedema coma, 60 micrograms via a stomach tube and then 20 microgram 8 hourly, or for thyroid toxicosis, 20 microgram orally, 8 hourly with carbimazole. Adverse effects include headache, restlessness, flushing, sweating, diarrhea, excess weight loss, palpitations, tachycardia, cardiac arrhythmias, skeletal muscle cramps and or weakness, and interactions include liothyronine may enhance activity of oral anticoagulants such as warfarin, and therefore prothrombin times should be closely monitored. Absorption may decrease if given with cholestyramine, may increase plasma levels of phenytoin, increasing risk of toxicity. Metabolism may also be increased with phenytoin and carbamazepine. Increased risk of cardiac arrhythmias if given with tricyclic antidepressants. If given with oral contraceptives, increased dose of liothyronine may be needed. Ketamine may cause marked hypertension and tachycardia when given with thyroid agents. An increased Oral hypoglycemics and insulin may be needed. Blood glucose concentration should be carefully monitored. Stopping or starting anti-epileptic agents may alter dose requirement for life.
Upon Harumi's initial admission, the nurse should complete a health history as well as a comprehensive physical assessment. Completing a health history with the patient can uncover symptoms that can lead to a diagnosis of Hashimoto's thyroiditis, in particular symptoms of fatigue, weakness, cold intolerance, dry skin, constipation, menstrual disturbances in women, and especially infertility, menorrhagia, and weight gain. Furthermore, completing a health history for Harumi allows her the opportunity to provide input and knowledge into her own care plan, thus adhering to Standard 2 of the National Safety and Quality Health Services Standards. Following Harumi's health history, a physical assessment is performed during the initial admission. Taking Harumi's blood pressure, heart rate, temperature, and respiratory rate is important to provide a baseline for future referral to highlight any further deterioration in Harumi according to Standard 9. Bradycardia, as well as low blood pressure, can be also an indicator of hypothyroidism related to Hashimoto's and thus should also be closely monitored. Examining Harumi's weight and height, thyroid enlargement in terms of diffuse or nodular, muscle weakness, or if there is any evidence of myxedema in the skin can also be key indicators for diagnosis. Once the diagnosis is reached for Harumi, it is important for the nurse to administer medication in adherence to clinical guidelines and follow the 7 rights of medication administration in order to uphold Standard 4. Before giving Harumi her medication, the nurse is responsible for educating her on the reason and possible effects of the medication. They should ask the patient if they understand the importance of using the medication and make sure they are aware of all the possible side effects and how to take the medication themselves safely. Furthermore, they are responsible for determining if the medication is given for the right reason, via the right route, at the right time, to determine the right patient for the correct dose in accordance with the right documentation, and that is the right medication being given to the patient. Giving Harumi her medication is significant for her recovery, as either the use of thyroxine sodium or lithironidine sodium can ease the symptoms of hypothyroidism related to Hashimoto's and reinstate wellness for Harumi. Continued monitoring of the patient's T3, T4, and TSH levels via blood tests are used to determine the effectiveness of the pharmaceuticals and whether the doses need to be adjusted. It is the nurse's responsibility to continue to monitor Harumi over the course of their treatment to determine if there is any deterioration in her condition, in accordance with Standard 9, or if any progress has been made. Thus, regularly documenting changes in the patient's weight, fluid intake, and bowel movements can provide information about the changes in her condition and ensure that Harumi remains hydrated and continues to have bowel movements. A fluid balance chart should be implemented to monitor any fluctuations. In addition to monitoring weight, fluid input and output, daily measurements of the patient's neck circumference is vital for checking the progression of any further thyroid enlargement related to Hashimoto's. Educating the patient is an important intervention which can allow the patient to feel a part of a healthcare plan, as well as give them the ability to best care for themselves in the future. The nurse should inform the patient of the benefits of an iodine-sufficient diet to help minimize symptoms of hypothyroidism related to Hashimoto's thyroiditis. In addition, they should be informed of all the possible adverse effects of the medication that they are taking, as well as any further symptoms of hypothyroidism that may arise, particularly in regards to monitoring any extreme weight gain or loss that can occur in the future, as it may be an indicator of that the medication needs further adjusting. Thank you for watching.